Good morning, and thank you, Dr. Dragoo, for this opportunity to speak with you today. My name is Chris Rogers, and I'm a physiatrist in private practice in San Diego. First, I'd like to share a brief history of autologous cell therapy, and then I'll explain why I think they will be the best choice for treating patients with osteoarthritis symptoms. Here are my disclosures. So in the early 1990s, a new therapeutic technology was envisioned when Dr. Arnold Kaplan was the first to describe how a small group of human progenitor cells might lead to bone and cartilage tissue repair, and he named them the mesenchymal stem cell, or MSC. For 20 years, Dr. Kaplan and his colleagues had been studying the conditions required to cause the MSC to differentiate along several mesenchymal cell lineages. However, did you know that one of his key collaborators was an orthopedic surgeon and a pioneer in the understanding of bone growth and repair? Dr. Marshall Urist was a professor at the UCLA Department of Orthopedic Surgery, and you can see the influence that he had on Dr. Kaplan's early thinking. As testimony, Dr. Urist's picture still hangs on the wall in Dr. Kaplan's office. Back in the early 1980s, while I was still in high school, I was fortunate enough to work in the UCLA Bone Research Lab, the same lab where Dr. Urist had discovered the growth factor BMP. Dr. Urist inspired me to pursue a career in medicine, and 40 years later, I still have the book that he gave to me, my first orthopedic textbook, titled Bone. Since those early years, the understanding of how MSCs work in the body has evolved. While it was originally thought that these cells would engraft in the host and differentiate into bone or cartilage tissue, later it became known that these cells influence tissue repair by several different kinds of mechanisms of action. First, they will home to a site of inflammation or injury. Then they will secrete hundreds of cytokines, growth factors, and exosomes that modulate immune cells, decrease inflammation, and promote tissue regeneration. This was intriguing to me because we all care for osteoarthritis patients who don't respond to conservative care, but for one reason or another are not yet a candidate for a total joint arthroplasty, and therefore they fall into this treatment gap, where they may suffer with symptoms for many years. Now, PRP, which does not contain MSCs but is a rich source of growth factors and cytokines, has demonstrated safety and efficacy in several placebo-controlled randomized clinical trials. And even though in our clinic we have standardized methods for tracking cell counts and patient outcomes, in the published literature, the treatment lacks general standardization. Furthermore, it has been shown that PRP is less useful for moderate to severe disease. The same is true for bone marrow aspirate concentrate, which contains a small number of MSCs, immune cells, growth factors, and cytokines, including IRAP. And there is some good data for safety and preliminary efficacy data in several case series, but currently there's only one placebo-controlled randomized controlled trial, and again, the treatment generally lacks standardization in the literature. In 2016, I was fortunate enough to have dinner with Dr. Kaplan and his former research fellow, Dr. Konrad Slanarski, an orthopedic surgeon from Europe, who had been using microfragmented adipose tissue for his patients with knee osteoarthritis. MFAT is a heterogeneous collection of cells, including pericytes and MSCs, obtained by rinsing and resizing a patient's own lipoaspirate. They introduced me to this new FDA-compliant device that had been shown to be effective for treating knee arthritis patients in Europe. At that same time, I was intrigued by work being done with stromal vascular fraction, which is a heterogeneous collection of adipose tissue-derived cells, isolated by enzymatic digestion, which showed promise, and summarized in this meta-analysis shows increasing effect sizes when compared to other forms of intra-articular injections such as corticosteroids, hyaluronic acid, PRP, and others. Even more impressive were the outcomes that were found in well-designed placebo-controlled clinical trials of culture-expanded MSCs derived from bone marrow, adipose tissue, or umbilical cord tissues, with the adipose tissue showing some superiority to the other cell types in this meta-analysis by we. And in 2014, Dr. Chris Joe and his colleagues published their results with culture-expanded autologous adipose-derived MSCs using 6-month follow-up arthroscopy and biopsy to demonstrate hyaline cartilage regeneration in some of their patients. But as you've heard, the FDA regulates SVF and cultured MSCs as a drug, so they're not yet available for patients outside of an FDA-approved clinical trial. So I was convinced by Dr. Kaplan and Dr. Sonarski to offer MFAT to my patients, And the first patient I treated was a retired firefighter who had moderately severe knee osteoarthritis and had failed conservative treatment, including hyaluronic acid and PRP. And he had very good clinical outcome and continues to do well even 6 years after treatment. So I'd been tracking my data, as had Dr. Gobi and several others. So we last year decided to publish this retrospective multi-site international study of 75 elderly patients with moderate to severe knee osteoarthritis. And we were able to demonstrate good safety and efficacy with a minimum 2-year follow-up. And there are several other studies like this with follow-up as long as 3 years. However, at this time, there are no placebo-controlled randomized clinical trials, and the variations in the processing makes it difficult to know why some of our patients might be non-responders. One of the challenges of technology like bone marrow and aspirate, concentrate, and MFAT are that these procedures are not standardized, and we're not really quantifying what's in the biologic. So we don't know cell type, cell count, viability. We're not testing for bacterial contamination. The techniques are highly operator dependent. And even though there are 510(k) approved devices, we're not yet able to make claims for any orthopedic indication. And furthermore, if your patient needs a repeat treatment, which is highly likely, as many of these patients need treatment within 1 to 2 years, repeat harvest procedures are necessary. So what does the future hold? Well, I think it includes FDA-approved autologous cell products that would be manufactured in an FDA-inspected central lab. And this allows us to have a standardized cell dose that would be well characterized with flow cytometry, with known viability, potency, and purity, and we're able to test for sterility, endotoxin, and mycoplasma. And so we conducted a phase 1/2A clinical trial that was approved by FDA on stromal vascular fraction for patients with knee osteoarthritis. And these results are not yet published, but we do have our one-year follow-up data on safety and efficacy, showing both good safety and preliminary efficacy, with most patients meeting MCID and 75% satisfaction at 12-month follow-up. Okay, so if you're Obi-Wan Kenobi and you've got knee pain, do you want Luke's young donor cells or do you want your own Jedi Master cells? I would argue that for 3 reasons, efficacy, safety, and cost, you might want your own cells. But first I have to dispel some myths. First myth is that your own cells are ineffective. And while in the Petri dish it has been shown that younger cells proliferate at a higher rate and have other properties that are desirable, it's really the clinical outcomes that matter. So if you look at some of the clinical studies performed by Dr. Felipe Hernigau over the last 25 plus years, he showed that in a cohort of patients with average age 75 years old, that when he used their own bone marrow aspirate concentrate for an intraosseous injection, that he was able to see very good safety and efficacy data with 15-year follow-up. And in another study performed in Europe using autologous stromal vascular fraction cells, patients with an average age of 83 years old were also able to see very good clinical outcomes. So if you look at the published literature on autologous and allogeneic cell therapy, they're really very heterogeneous in terms of their design and how they actually process or even count cells. And so I tried to find papers that would help us look at a little closer, and I found these 2 papers that were published by the same authors using similar study designs with similar inclusion and exclusion criteria. And they actually manufacture the cell with a similar process, the only difference being that in one study, the patients received their own cells, where in the other study, they received a donor cell. That donor cell average age was 27 years old. And if you look at these 2 studies side by side, you see the baseline characteristics in terms of severity of the condition, the duration of symptoms, age, BMI are very similar. Similar baseline characteristics in terms of pain and function. And then in both studies, patients received 50 million cell dose, 2 separate doses. Again, the only difference being one is an autologous source, the other is allo source. And at 12-month follow-up, they showed similar, if not better, outcomes in the autologous group in terms of pain and function, but also improvements in cartilage were seen on MRI in the autologous study, whereas they were not seen in the allo study. And then finally, safety was comparable in both studies. The second myth is that the allo cells are immunoprivileged and evade the immune system. And that's because when they're in homeostasis, they do not express class 1, they do not express class 2 MHC molecules and low levels of class 1 molecules. However, when these cells are put into an inflammatory environment, such as an inflamed knee joint, they will upregulate the class 1 and class 2 molecules, which then identifies them as targets for the host immune system. Furthermore, significant antibody production is produced after that first injection, which then primes the host immune system upon repeat injection, which has showed that there's now greater clearance of these cells from the joint. And then, of course, the disease transmission is always a risk. There are new strains of viruses and others that may go undetected, and that's going to be a bigger risk with your allo products. And then finally, there's this issue of cost. And there's assumption that allo products will cost less, and that's because the production costs are very low. But every dose is going to cost the same regardless, and patients will need repeat doses. And the other cost that doesn't get recognized is the cost to bring it to market. There's a high bar to cross with FDA regarding the efficacy and safety balance. And Mesoblast has been trying to bring an allo-cell product to market for 18 years and spent over $1 billion. And that cost is probably going to go into their product. And they still do not yet have an FDA-approved product. And with autologous cell banking, you can actually drop the cost of repeat injections dramatically as there are no additional production costs, and storage is very cheap. So in summary, autologous cells are the best choice. We have autologous cell therapies, which are not stem cell therapies, but tissue grafts that are available now. You can expect both approvals for auto and allo cultured cell products in the future, but I think you're going to see better safety regarding immune reactions and disease transmission in the autologous products. There's already been evidence of efficacy with autologous products in several placebo-controlled randomized clinical trials, and we think there'll be better cost effectiveness as well. So thank you very much for your attention.